Hello, I'm Nathan McDannold, and I'm going to talk about the parameters that we use for blood-brain barrier opening. The parameter space that we have with blood-brain barrier opening with microbubbles is quite large. It depends on the frequency of the ultrasound, the length of the burst that we use, how fast we repeat those bursts, how long the total sonication is, as well as potentially the microbubble agent and the dose of microbubbles we use. And for each parameter setting, the pressure amplitude will produce, changing the pressure amplitude will produce different results. Typically, the pressure amplitude is less than 1 megapascal, but again, that depends on the other sets of parameters. Frequency is possible to disrupt the blood-brain barrier over a very wide range of frequencies. As you use a lower frequency, the threshold tends to go down. You can see from this study from a long time ago where we compared the threshold, and it seemed to match the mechanical index with a threshold of about 0.47 with these parameters. But as I mentioned, you can do this over a very wide range. This is a study from Kathy Nightingale where they used a 5.7 megahertz imaging system to disrupt the blood-brain barrier. And this is a different study by Howley Liu where they used 28 kilohertz to disrupt the blood-brain barrier. So it's possible over a wide range. Typically, we use between 200 and 700 kilohertz to get through the skull. The burst length will have a big impact on how, at least over some range of the threshold and the amount of opening that you get. You can see here, this is another study from a long time ago that we did where if you increase the burst length from 1 to 10 milliseconds, we see a big change in intensity, and we also see a reduction in the threshold. People have looked at a wide range of bursts as well. This is a study from Megan O'Reilly where they did single cycle excitations to avoid standing waves, and they were able to get opening there. There's also a lot of nice work in this area from James Choi, from where he is now and from when he worked back in Columbia. The pulse repetition we use typically is between 1 and 10 hertz. Other people have looked outside this range as well. The duration of the sonication also has a big effect on the opening. Here, this is a study by Rajiv Chopra where they looked at different exposure levels, and you can see that you study a lot more opening if you sonicate for a longer time. However, they started to see the incidence of damage increase as they use longer sonication. So there's probably a limit about how much we can increase the opening by expanding the duration. Others have looked at very short duration. 6 seconds is a group used by the group in Australia who are looking at Alzheimer's, and they were able to get nice opening to even very short duration sonications. People have done opening with all of the commercial microbubble agents. I haven't seen a huge difference between them. They've also looked at, research agents. This was a study by James Choi when he was at Columbia, where they compared a large microbubble agent to a small microbubble agent. And you could see that there was a better opening when they had a large microbubble agent. So the properties of the bubble may have an impact on the outcome. But with the commercial agents, I haven't seen too much. Typically, we use a fraction of the clinical dose or up to the clinical dose in our experiments. Other groups have used much higher doses, up to 100 times the clinical dose. As long as you have microbubbles, you're going to get some. But if you increase it, you may get more. There are a number of complicating factors that might impact the opening for a set of parameters. We've been looking at anesthesia, so we see a big effect when we compared isoflurane oxygens and ketamine xylazine. And that turned out, I think, to be largely due to the presence of oxygen, as when we replaced the oxygen in the isoflurane, we saw much more opening when we used medical air. This may just be an issue in very small animals. I've heard that this is less of an issue in large animals. Steroids may also have an impact. This was a study out of Sunnybrook where they compared the disruption with dexamethasone. And they see with this agent that the barrier seems to close faster than when when you don't have the steroid involved. You can also impact the disruption by sonicating the brain before you apply the microbubble enhanced sonication. This has been seen by a couple groups here by Ji-Young Park and also by Richard Price's group. When they sonicated the brain without microbubbles, they see an increase in the disruption. And you can see that it can be quite a big effect. So this is something to keep in mind, that we could maybe boost our opening by sonicating without bubbles first. One of the other issues is how do we define when the barrier is open and what is the magnitude of the opening? And that really depends on a number of things. And then you can define this as in different ways. You could talk about the amount of the drug or whether it was delivered or not, what size agents cross, might define the magnitude of the opening, how deep it might go, or how long it's open. To illustrate this, the size of the agent here, this is a study from Columbia, and you can see with a small agent, you get nice opening. A large 70 kilodalton dextran agent, you get also get delivery of the agent, but it's closer to blood vessels. And then with a large agent, they didn't see much at all. So if you are using this large agent, you may say the barrier is closed when it is clearly not. Similarly, how far the drugs penetrate, they also depend on your parameters. This is a study that came out this year by Richard Price, where they did look at all of the cells that were being transfected after BBB opening, and you can see that depended on the pressure amplitude that they use. So for something like a brain tumor, it's very important that we get drugs to infiltrating cells. So we need to we depend on the parameters that we use, whether or not we get those cells to where they need to be. The duration of the opening is also important, and they may depend on the parameters we use, but this also depends on the size of the agent. Here, typically, we for an MR contrast agent or a small molecule, the half-life is a couple hours. But when you use a larger agent, the barrier appears to close much more quickly, and small agents will be open for a very long time. So depending on when you're looking at the disruption, you may conclude that the barrier is open or closed, but it may be open for some things and not open for other things. In brain tumors, this is also a complication. Here we looked at, this is a study we did a few years ago, where we looked at sonicating tumors and delivering MR contrast agent and liposomal doxorubicin. In early stage, at day 9 after we implanted the tumor, we saw a big increase in the delivery of the gadolinium agent, but at days 14 and 17, we did not see any difference. Here, the barrier was already very leaky, and we couldn't improve upon it. However, when we looked at the liposomal doxorubicin, we still saw a large increase in the size. So the barrier may be open here for a large agent, but it's not open for a small agent because it's already very leaky to begin with, and we really weren't able to improve upon that. We also need to keep in mind the threshold that we work at. So if we need to be able to see what we're doing. So this was a study we did in a monkey where we sonicated the cingulate cortex. We targeted these areas. You see in the cingulate, we see nice opening, but in the neighboring white matter, there was no apparent opening in MRI. But later in pathology, we saw that we did see blue dye delivery. So just because we don't see the opening doesn't mean it's not there. And this is really important in brain tumors because a lot of the targets that we're going to be going after are in white matter infiltrating. So we need to think of ways to improve the sensitivity of our detection. And we may be making wrong conclusions saying that the barrier is open or not because the vascular density is so low and it's so hard to see the disruption in white matter. And finally, there's the question of whether there are optimal parameters. And as I tried to explain, the blood-brain barrier is open over a huge range of acoustic parameters. You can do it basically it's very easy to use any parameter and get opening. I don't see any consensus on optimal parameters. If I were to design an experiment to say what is the optimal parameter, what I would do is try to see if we can maximize the safe window. So here's a plot of pressure amplitude and the probability for whether or not we had blood-brain barrier opening. And you can see that the safe window where we can get disruption without seeing vascular damage is quite narrow. So what I would like to do, it would require a lot of views, but we could measure this sort of curves for different parameters and try to find ones that maximize this safety window. So I think that's the way we should be doing it to get the optimal parameters. But right now, I don't think there's any consensus on this. And with that, I'm going to stop and thank you very much.